Welcome back. Today we are going to discuss about the management of drug-resistant gram-negative infections with a focus on carbapenem-resistant infections. So before going into the topic proper, let's quiz a little bit based on what we have learned in the first two episodes. Identify this antibiotic. It has poor blood concentrations. It also has poor urinary concentrations. No pseudomonal coverage. It doesn't penetrate well into the blood-brain barrier. The moment you infuse this drug, patient will tell us about nausea. It can cause pancreatitis. When used for prolonged time, it can cause liver injury, coagulopathy and hypoglycemia. Sounds like tigecycline, right? What about this antibiotic? It has a very good action against Escherichia coli, possibly may cover Klebsiella pneumoniae, not so good against Pseudomonas and has no activity against Acinetobacter baumannii. It has a lot of sodium in it, can cause hypernatremia, hypokalemia, fluid overload and worsening of heart failure. In critically ill patients, because of the hypernatremia, it can cause ventilator patient asynchrony. So probably we are talking about fosfomycin. What about this antibiotic? There are some bugs which are intrinsically resistant to this antibiotic like Burkholderia, Elizabeth Kingia meningoseptica, Morganella proteus providentia. It can cause AKI in approximately 20% of the cases with no pre-existing renal dysfunction, and the rates of AKI can jump up to 60% if there is any pre-existing renal dysfunction. Can cause significant neurotoxicity, but often underreported. It can cause severe muscle weakness after the infusion of the antibiotic. The PKPD of this particular antibiotic is so bad that we don't report it as susceptible. We rather call it as intermediate if the MICs are within clinical breakpoints. The routine automated blood culture system like Vitek2 is not great for susceptibility testing. Obviously, we are talking about polymyxin. So remember, we are trying to tell that polymyxin as an antibiotic is so poor. Just because we don't have any other option, we are still using polymyxin in our clinical practice. Identify this antibiotic. It has no activity against Pseudomonas and probably anaerobes. It is very effective not just against bacteria but some parasites like Toxoplasma, some fungi like PCP. It can cause a non-anic gap metabolic acidosis and hyperkalemia because of its action on aldosterone pathway. It has almost 100% oral bioavailability. So whether you are giving this antibiotic IV oral, it doesn't matter. It's a good oral choice. So we are talking about an antibiotic called cotrimoxazole, which is a combination of sulfamethoxazole and trimethoprim. So there are many newer antibiotics now, including Aztreonam avibactam, cefepime taniborbactam, cefderichol, plazomicin, and cefepime zidibactam. These are different antibiotics which are available to manage carbapenem-resistant infections. Among this, Aztreonam avibactam and plazomicin are already available in India. Cefepime zidibactam is going to be launched after some time. We don't have cefderichol and cefepime taniborbactam in India yet. So let us go to our proper chapter 3, the management of carbapenem resistant infections. So we are going to discuss mostly about Acinetobacter, Pseudomonas, Klebsiella and E. coli because these four bugs they constitute around more than 90% of gram-negative infections in intensive care units in India. So many of these bacteria initially which are thought to be kind of colonizers or not so resistant because of the antibiotic stress in ICU, eventually they evolved as drug resistant clones. So it is just like survival of the fittest. So among all these bacteria, even some other bacteria which belong to spice group or Stenotrophomonas or Elizabeth Kingia, which can happen in intensive care units, all of them have few things in common, like drug resistance. That is the reason why they have been selected. All of them have ability to form biofilm. So if there is any prosthetic equipment which is very common in intensive care unit inside the patient's body, these bugs can form a biofilm around the prosthetic equipment. Some of the bacteria like especially Acinetobacter has a very low metabolic requirement, so it can survive even in dry surfaces for weeks together. Some of these bacteria in fact they can survive disinfectants and chlorination. So the four common bugs which we are going to discuss today are Acinetobacter pneumoniae, Klebsiella, Pseudomonas aeruginosa, and Escherichia coli. Klebsiella pneumoniae and Escherichia coli are normal gut colonizers. So in critically ill patients, a patient can have a E. coli gut translocation or Klebsiella gut translocation, can have a bacteremia. Because these are normal gut colonizers, it is not required always that your infection control is bad. If you are having a lot of Klebsiella infection, it is possible that the infection is endogenous. But that is not the case with Acinetobacter and Pseudomonas aeruginosa. With Acinetobacter and Pseudomonas aeruginosa, both are non-lactose fermenters. If you are having a lot of cases of Acinetobacter or Pseudomonas, that means there is some problem with infection control. Interestingly, Pseudomonas requires wet surfaces. So when you are seeing a lot of Pseudomonas in your ICU, probably you should be looking at the plumbing system, whether the water is okay, wherever there is wet environment is there, you have to look into those areas. Whereas Acinetobacter can even survive in dry surfaces. So the hand hygiene becomes very important. It can stay in the pillows of the patient who is colonized with Acinetobacter, in the bed rails. So you are looking at dry surfaces like a laptop, if it is there in ICU, the systems. So we are looking at the dry surfaces. So in an infection control point of view, Acinetobacter and Pseudomonas aeruginosa are little different. So let us look into the virulence factors of these four common bugs. So Acinetobacter, Acinetobacter is not very virulent. It tries to survive. It is a great survivor. It tries to persist by keeping the metabolic activity very low, by forming biofilms, by becoming extremely drug resistant, by taking all the genes which are required for drug resistance. But as such, it's not a very virulent bacteria. So usually, the clinical progress of patients infected with Acinetobacter will be very slow. That is one of the reasons why we keep having difficulty in identifying whether the patient is infected or just colonized. Most of the intensive care unit patients are admitted with some other primary diagnosis, and after that you isolate Acinetobacter from ET aspirate. The oxygen requirement might have worsened because of n number of reasons in ICU. Could be because of fluid overload, could be because of pulmonary thrombosis, could be because of pneumothorax or pleural effusions, which are very common in intensive care units. But then you isolate an Acinetobacter, you really don't know whether this is causing a worsening of oxygen requirement or not. Patients might not be systemically ill like we see in some other gram negatives like Klebsiella and E. coli. There is a reason for that. Acinetobacter has a lipopolysaccharide. Usually all other bacteria has lipopolysaccharide in their outer surface. Many of the bacteria gram negatives which we are discussing. But Acinetobacter has lipo-oligosaccharide. It is structurally little different. It doesn't stimulate the toll-like receptor 4 very well. So the NF-kappa beta pathway and TNF alpha secretion won't be very great. So many of the times these patients might not have a very high procalcitonin despite of having bacterial infection. So Acinetobacter is more of a survivor, low virulence but high mortality because of resistance of Acinetobacter. What about Pseudomonas? Again, Pseudomonas is a non-lactose fermenters, but Pseudomonas, has a lot of enzymes like exotoxins, and it also has a lot of enzymes which can break the tissue. It also has a lot of siderophores like pyocyanin. So it is kind of virulent as well as drug resistant. What about Klebsiella pneumoniae? Klebsiella pneumoniae, people used to think that there is a variant of Klebsiella pneumonia which will cause a lot of virulence, like the clinical presentation will be very aggressive. But Klebsiella has to either, it can either be virulent or can be resistant. That is the conventional way of thinking, because the enzymes require to become resistant and the enzymes require to become virulent. Both are a lot for a single bug, so there is a fitness cost to have both of them together. So if some bacteria is having both virulence and resistance, probably it might not be able to survive because of the metabolic demand it is going to have. But that is not true anymore. There are a lot of ICU acquired Klebsiella pneumonia now are hypervirulent. This is very very important. So these hypervirulent strains are basically identified by their ability to form thick capsule. We call them as K1, K2, K3 serotypes based on the capsule. So they are very hyper hyper mucus colonies they will form. So we can identify the hypervirulent Klebsiella by something called string test, but it can also be identified by testing genes which code for these capsules like RMPA and MAGA. and other siderophores like Aerobactin, Enterobactin, Yersinia, and Salmonellin. So we'll be discussing more about it, but we have to know that Klebsiella is changing itself. Now it is becoming both hypervirulent as well as resistant. What about E. coli? E. coli again a gut commensal, doesn't have very thick capsule like Klebsiella, but however there are some changes in E. coli, especially in India. Penicillin binding protein 3 substitution of 4 amino acids is causing a lot of issues, especially with this newer BLBLI. The PBP3 mutations are leading to resistance to many of the newer antibiotics. We'll discuss about that in detail. What about resistance mechanisms? We have already discussed in Acinetobacter, unlike Klebsiella or E. coli, where OXA48 and NDM are the common mechanisms of resistance. In Acinetobacter, we have other OXA enzymes, other than OXA48, like OXA23, 24, 15, and 58. They are the main cause for resistance. And there are most of the beta lactamase inhibitors, newer beta lactamase inhibitors like ceftazidime avibactam or acinam avibactam or cefepime taniborbactam. They are not very effective against non-OXA48 enzymes. So the only newer beta lactamase inhibitors which is very effective is durlobactam, which is a non-suicidal second generational beta lactamase inhibitor. We have discussed about it. Unfortunately, approximately 50% of Acinetobacter isolates in Indian ICUs are NDM producers as well. So sulbactam, durlobactam is not effective against NDM. We'll discuss more about it. What about Pseudomonas? In India, NDM production is Pseudomonas again is common, but other common metallo-beta like beta lactamases produced by Pseudomonas are VIM, and IMP, where again the newer beta lactamase inhibitors have variable inhibitory action on these enzymes. Efflux pumps are again important. The new generation R&D efflux pumps like ADABC in Acinetobacter can cause resistance to multiple antibiotics including tigecycline. We have discussed about MEX, AB, OPRM efflux pumps which are important in carbapenem resistance in Pseudomonas aeruginosa. And ACR-AB Tol-C or ACR-AB Tol-C can be cause of resistance in E. coli and Klebsiella, though not commonly seen. What about porin channels? We have discussed a lot about OPRD porin channels causing resistance to mepenem in Pseudomonas. OMPK36 porin channel mutations can lead to differential susceptibility to ertapenem and meropenem in Klebsiella pneumoniae. Pseudomonas is known to produce a lot of AMPs, which we call it as PDC. So Pseudomonas derived cephalosporinases, very common in patients having Pseudomonas aeruginosa. So let us discuss about all these bacteria one by one and see how we can manage the bacteria at the best. The most important Acinetobacter, which is there in across the ICUs in India and in the world. So in 1960s and 70s, where Acinetobacter used to be just a hospital colonizer, not known to cause human disease, but in early 70s we started having Acinetobacter infections, and in 1990s and 2000s it started becoming more and more resistant. In 90s it used to be carbapenem susceptible, but then with a high carbapenem use it modified itself to become carbapenem resistant. Now in India, if you see, most of the hospital acquired Acinetobacter isolates will be by default carbapenem resistant to the tunes of probably 90 to 100%, right? Then so now we are having Acinetobacter infections in India with almost 100% carbapenem resistance, with options, antibiotic options like polymyxins and glycycycline for the treatment. So interestingly, across the world, Acinetobacter has evolved into three distinct lineages. The most common is international clonal lineage 2, which is seen in India and across the globe. So basically, if you are having Acinetobacter in your ICU, and if you go to some other part of India, they are also having Acinetobacter. If you do typing sequencing of these patients, both will be IC2. So this is very interesting because Acinetobacter somehow has evolved into three distinct lineages which are common across the world. Okay, that is not true for something like Pseudomonas. So Pseudomonas, there could, if you do a sequence typing of two different isolates within the same hospital, it will be different. So that is the reason why your Acinetobacter is like my Acinetobacter, but your Pseudomonas is not my Pseudomonas. So the there are variety of mechanisms of resistance. We discussed about the non-OXA48 enzymes, but again Acinetobacter have a these highly mobile insertion sequences which keep on moving across the genome. Sometimes uh, they club these resistance genes in between two insertion sequences, and they take it and put it somewhere else in the same genome. So that will lead to sudden switch in the way Acinetobacter behaves, both phenotypically and resistance wise. So basically, you can see there is a rapid evolution of Acinetobacter under antibiotic pressure. So this genome keeps on changing. These mobile elements, they constantly shuffle. They create a new combination of resistance as well as virulence. So Acinetobacter, it keeps on changing within the host. And sometimes when you see Acinetobacter initially, when you isolate, you might see that it is kind of susceptible to many of the antibiotics. But Acinetobacter wants to survive so much that it will even take up the neck DNA from the environments. So sometimes there are something called resistant islands. So these are the islands of genetic material which will have a lot of multiple resistance genes for different classes of antibiotics. So one multi-resistant genes island can have beta-lactam, aminoglycoside, sulfonamide resistance. So suddenly the so-called bug, which is otherwise susceptible to all the antibiotics, can suddenly switch into something which is completely resistant to all the antibiotics just because of a horizontal gene transfer. For example, in international clone lineage 1, because of the transfer of ABR and genetic island, it can accumulate up to 45 resistance genes at one genetic transfer. So this is very, very important in Acinetobacter. So in India, the additional problem is Acinetobacter also produces a lot of NDM. Approximately 50% isolates of Acinetobacter can have NDM along with it. So the drug something like Durlobactam might not be very effective in all isolates of Acinetobacter in India. So what treatment options we have to treat Acinetobacter? We have discussed about polymyxin based regimens in combination with either high dose sulbactam or minocycline or tigecycline. We also have newer antibiotics like Serbactam, Durlobactam, and Cefidericol. Both the trials are published already for Cefidericol and Sulbactam, Durlobactam, but these two drugs are right now not available in India. Cefepime zidibactam in combination with sulbactam can be an option, but the data is not there at, right now. Probably we are looking at a publication very soon. So let us move to the polymyxin. So at present time for the treatment of Acinetobacter, we are really using only polymyxin based therapy. We have discussed about the polymyxins, how bad they are in PKPD wise. So if you are using polymyxin B as a treatment, the area under curve by MIC is 50 to 100 is what you are expecting. That will correlate approximately with 2 to 4 of trough values. But remember, trough values do not correlate with AUC by MIC very well. So if you are really want to do a PKPD adjustment, probably you have to calculate AUC by MIC rather than extrapolating AUC by MIC, thinking that it has a linear kinetics by multiplying it with 24. Okay. So this is the AUC by MIC if you want to achieve, and this is almost very difficult with a conventional dosing which we are using. So if the patient has a MIC of more than 1, then it is impossible for you to cure the infection by giving polymyxin based regimen. Another issue is it has a very small therapeutic window. We discussed a lot about the adverse events of polymyxin based regimen. So the question is, can we really do a therapeutic drug monitoring, measure the polymyxin AUC by MIC levels, and adjust the dose of polymyxin so that we can have a maximal benefit with less side effects? So this has been studied in one interesting randomized control trial in China, PMB cross RCT, where they have done a multicentric open label RCT included around 300 patients. They have used two doses of polymyxin. One is 15 lakhs bolus dose followed by 7.5 lakh BD, and the other dose is 10 lakhs and 5 lakh BD. So this is really very underdosing. We don't really routinely use the lower dose. So we in fact use many of the times 20 lakh loading followed by 10 lakh BD based on the patient's weight. So we go for approximately 15,000 international units per kg per dose. But this is little bit underdosing. But at the same time, they have done a therapeutic drug monitoring. So if the drug levels are not within therapeutic drug range, they have increased the dose by 25 mg or decreased the dose by 25 mg. So this is a very interesting approach. And most of the patients actually received combination of antibiotics. So if you are using combination of antibiotics, probably it is very difficult to get a mortality difference because the other antibiotic might be equally effective. We don't have many antibiotics which are equally effective in Acinetobacter, but this could be one of the significant bias which we are looking at. So the primary outcome is to look at the 14-day clinical response, and the secondary outcome being mortality at different points and bacterial clearance, and to look at the AK incidence. So in this particular study, there was no difference between 14-day mortality or 14-day clinical response or 28-day mortality between these two groups. But you can see that patients who received higher dose, most of them, like 60% of them, actually had the therapeutic drug levels within the range, the expected range, whereas only 40% of patients who received 10 lakh stat followed by 5 lakh BD, they achieved the therapeutic range. So if you look at this one parameter, the number of people who achieved the therapeutic range, and probably 15 lakhs followed by 7.5 lakh BD had a better chances of reaching this AUC by MAC curves, right? In a small percentage of patients, approximately 10% of the patients, the 15 lakh followed by 7.5D, they cross the AUC of more than 100, so 11.8% is. But if you can look at the AK incidence, there is no significant difference in AK as such, even though there is a small percentage of patients who achieved higher than AUC. At the same time, when they try to adjust the dose by increasing or decreasing the polymyxin by 25 mg, they didn't actually able to change anything much. So you can do a therapeutic drug monitoring. You can adjust the doses based on the therapeutic drug monitoring, but probably the TDM will not translate into mortality benefit, or you might not be able to achieve the drug levels you want to achieve by increasing or decreasing the doses by 25 mg as done in this trial. So very interesting. It gives a clarity on whether we should be really pushing for therapeutic drug monitoring, especially in the view of newer antibiotics that are coming now. Based on single study, we obviously are not going to take any call in our daily routine practice. So how about combination therapy? Can we give high dose meropenem along with polymyxins even though there is a phenotypic meropenem resistance? That is one question. What about other antibiotic combination, high dose sulbactam? So sulbactam is interesting because it has an intrinsic activity against Acinetobacter. It binds to PBP1 and PBP3 of Acinetobacter very tightly. So if you can give a very high dose sulbactam which will kind of neutralize all the beta lactamases, and some amount of sulbactam which is left can go and bind to PBP1 and PBP3 and thereby acting on it. But the problem is it will only work in non-NDM isolates because NDM can break a lot of sulbactam. So whatever higher dose you are giving you might not be able to achieve sufficient sulbactam levels which can act on the Acinetobacter. So probably polymyxin with the high dose sulbactam could be a good option in patients who are not having NDM mediated resistance. Just oxa mediated resistance, if it is there, it can be useful. Colistin with high dose meropenem. There are two studies, IDA study and Overcome trial. Both the trials, it is not shown to be beneficial. Probably a little bit more side effects are there once you give high dose meropenem. The routine use right now is colistin in combination with tigecycline and minocycline based on the phenotypic susceptibility. So these are the two trials which we have discussed. IDA trial, which compared colistin with colistin plus high dose meropenem. Most of the patients had Acinetobacter. Most of the patients had a meropenem MIC of more than 8, and you can see there is no significant difference between combination therapy with monotherapy. Similar results we can see in patients in Overcome trial as well. In Acinetobacter or CRE or Pseudomonas aeruginosa, we couldn't see any significant difference to say that colistin should be used in a combination of high dose carbapenem. So, are there any new antibiotic options? There are, but they are not available right now in India. However, we'll discuss briefly about the newer antibiotic options. So sulbactam, durlobactam, we discussed a lot about durlobactam being effective against Acinetobacter oxus, oxa 23, 24, 51 and 58. So because durlobactam is effective, it will protect the sulbactam so that sulbactam can go and bind to PBP1 and PBP3 and thereby kill the Acinetobacter. That is the concept. So this sulbactam durlobactam phase 3 RCT, where sulbactam durlobactam is compared with colistin along with high dose imipenem cilastatin. So it is important to understand that if durlobactam is protecting sulbactam, durlobactam might also protect imipenem, and imipenem is a very strong binder of insulin binding protein too. So probably even imipenem cilastatin is also having activity. So that is the reason why at present it is recommended to use sulbactam durlobactam in combination with imipenem because of the study for the treatment of Acinetobacter. So the primary outcome was 28-day all-cause mortality. So total 181 patients were randomized, and 40% had renal impairment. Many of the patients had pneumonia, and you can see that there is a significant difference in mortality. And sulbactam durlobactam has done much well compared to colistin. It has a statistical superiority for the mortality in patients with Acinetobacter infection. So sulbactam durlobactam in combination with imipenem definitely looks like an exciting antibiotic if the Acinetobacter you are treating is non-NDM producer. What about other options? So there is a lot of interest in cefiderocol because of its very peculiar mechanism of action. They call it as Trojan horse mechanism. So cefiderocol binds to free iron, and it looks like a siderophore. Siderophore is a siderophore is a substance which will provide iron to the bacteria. So bacteria actually thinks cefiderocol as a siderophore and takes inside with the mechanisms which are siderophore mediated, not through the porine channels or efflux pumps. So by default, the modified porine channels or efflux pumps cannot cause resistance to cefiderocol. Now, cefiderocol is very similar, structurally very similar to ceftazidime. Once it is taken into the cell, it will go and bind to penicillin binding protein 3 and thereby killing the bacteria. In periplasmic space, there are a lot of enzymes, beta lactamases, but interestingly, cefiderocol is resistant to most of the beta lactamase, NDM, oxas, or KPC. So enzymatic degradation won't happen, and porine channels are ineffective. Efflux pumps are not causing resistance to cefiderocol. Looks like a perfect mechanism. So basically, you give bacteria siderophore like substance, it will take inside and it will kind of commit suicide. That is the mechanism of cefiderocol. Very, very interesting. Initial, there are four important RCTs with cefiderocol and many other observational studies. One is Apex UTI in UTI patients where imipenem is head-to-head compared with cefiderocol, and Apex NP where meropenem is head-to-head compared with cefiderocol in nosocomial pneumonia. Then we have Credible CR and Game Changer. Credible CR study is done in patients with carbapenem-resistant infections proven. Game Changers trial is done in a patients who are more likely to have carbapenem resistance because of their hospital stay and other risk factors. So in Apex UTI, cefiderocol is found to be superior to imipenem in UTI patients. You can see that there is a very significant difference in composite success and microbiological outcomes. What about nosocomial pneumonia? Again, cefiderocol is head-to-head compared with meropenem. Both the arms received linezolid, and most of the patients here again CRE, Klebsiella pseudomonas and Acinetobacter. But these patients are not carbapenem resistant. Approximately 20% of this trial had carbapenem resistance, and you can see that cefiderocol is non-inferior to meropenem in this particular trial. So when you are comparing head-to-head with meropenem or imipenem, it has done equally good both in UTI and in hospital acquired pneumonia. So there is a third trial where they tried to compare cefiderocol head to head with a best available therapy. Most of the times this best available therapy is polymyxin. We keep on discussing about polymyxin being a bad antibiotic because of its PKPD or side effects. So here we expect cefiderocol to do much better compared to the best available therapy. It did in the terms of clinical cure. It did in the terms of microbiological eradication. But when you look at the mortality rates, there is a gross difference. Patients with cefiderocol died more, approximately twice. There is no exact reason why there was a higher mortality in cefiderocol arm, but the mortality in this particular study is driven by Acinetobacter isolates. So people thought probably there is some peculiar mechanism in Acinetobacter that might be leading to higher mortality in Acinetobacter. In subsequent trials, it becomes a very interesting point to look at individual organism-wise mortality in these patients. So recent game changer trial where they tried to include the patients who are at higher risk of developing carbapenem resistant infection, but unfortunately only 25% of the isolates in this particular study is carbapenem resistant. But in this particular study, again, you can see that most of the patients are immunocompromised, up to 60% of the patients, 20% required ICU admission, and only 20% in each, 25% in each arm are carbapenem resistant. So this study again, there is a no significant difference between the mortality mortality between cephalosporin and standard of care arm. Even in Acinetobacter subset, there is no significant difference in mortality. But interestingly, in this particular study, there is a higher mortality in Enterobacter form. So in E. coli and Klebsiella, you started seeing higher mortality. Probably this is most of these isolates which failed on treatment. They had a PBP3 substitution, which we discussed about E. coli, how 4 amino acid substitution from wire to wire it can lead to resistance to antibiotics which act through PBP3. Remember, cefidericol has to go and bind to PBP3, and if there is a mutation in PBP3, it might not be effective. So in this particular study, again, there is a numerically higher mortality in all carbapenem-resistant infections in this particular study. No, though even though not statistically significant, and the numerically higher mortality is driven predominantly by PBP3 mutated Enterobacter. So in India, what is the relevance? In India, probably it is not good for E. coli because many of the times E. coli, more than 80% of E. coli have this PBP3 mutation along with NDM5 that can lead to resistance to cephalosporin. In Acinetobacter, probably yes. For Pseudomonas, probably yes. In carbapenem resistant Klebsiella, we definitely have a better options like Aztreonam. Let's move to Klebsiella pneumoniae. So this is one of the picture which is showing string test positive hyperviscoid strains of Klebsiella pneumoniae. So worldwide, uh, uh, Klebsiella pneumoniae is dominated by sequence type 258. HT11 is in China. It produces a lot of KPC, but in India, most of the strains they produce NDM and OXA48. So the two dominant lineages in India are HT147 and sequence typing 231. So in India, most of the Klebsiella isolates they even either produce OXA48 or NDM or combination of these. KPC producing Klebsiella pneumoniae in India are very rare. That is the reason why we are not going to discuss about antibiotics like meropenem vibobactam, which are very effective against KPC, right? So, as we discussed, for the bacteria to become both virulent and resistant in Klebsiella, it will have a fitness cost. But somehow Klebsiella has managed it now. Approximately in some of the studies, approximately 10% of hospital acquired Klebsiella, it is showing hypervirulent strains. So this is going to be very important because if you are having a HVKP, ICU acquired infection, it causes liver abscesses, endophthalmitis. So the duration of treatment might change. You cannot just treat with antibiotics for a week and leave HPKP strains. And the mortality might rise if there is any delay in choosing right antibiotic with the HPKP strain circulating in the hospitals. So the hypervirulence in HVKP strains, that is hypervirulent Klebsiella strains, is because of two important reasons: the genetic mutations which regulate capsules, the genetic material which regulates capsule, which is RMP A and A2 and MAGA, and because of siderophores like Aerobactin, Salmonellin, and Yersinobacter and Enterobacter. So this siderophores, the bacteria is able to quench a lot of iron and grow faster, evade the host defenses and oxidative stress, and thereby causing virulent presentation. So this is the string test. If you have more than 5 mm of the string, then it is positive. This is the endophthalmitis with HVKP. And in liver abscesses, you can see very different signs. You can see honeycomb sign with HVKP. This particular image shows a turquoise sun. It looks like a turquoise material where you can see liver abscess having a partially divided septa, very thin septa within the liver abscess, right? So this is how we are going to probably clinically and microbiologically identify Klebsiella, hypervirulent Klebsiella. What are the treatment options we have for Klebsiella in India? Aztreonam or combination of ceftazidime-avibactam and aztreonam. So it is very effective antibiotic, and in most of the times in India, if you have a hospital-acquired infection and if you isolate Klebsiella pneumonia, the treating team is kind of happy because you know that you can nail it. So Aztreonam-avibactam is recently available. Before that, because we didn't have a Aztreonam-avibactam combination, we used to use a ceftazidime-avibactam with aztreonam combination. So the principle was ceftazidime-avibactam, is effective against other enzymes, other ESBLs, KPC, and OXA48, whereas aztreonam has activity against NDM producing enterobacterial. So we have discussed about it. So basically, if you combine both aztreonam and avibactam, ceftazidime avibactam will protect aztreonam from all these enzymes, ESBL, KPC, and OXA48, so that aztreonam can go and bind to penicillin binding protein 3 and thereby killing the bacteria. Again, aztreonam goes and binds to penicillin binding protein 3, and PBP3 substitutions in E. coli actually can cause resistance to this combination as well. So this was the principle. So we used to use 2.5 grams of ceftazidime-avibactam along with 2 grams of aztreonam infused simultaneously 3 times a day. And there are multiple observational studies with this, and you can see that the combination of ceftazidime-avibactam with aztreonam has shown to decrease the mortality at least by 50% in patients producing metallo-beta-lactamases. So once we had Ashinam avibactam now, probably we will be using more of Ashinam avibactam. But ceftazidime does have binding ability to penicillin binding proteins. So whether ceftazidime is adding on top of Ashinam avibactam is something which we have to look into. It will be very interesting to look into. One of the advantages of having Ashinam avibactam as a compound is the better ratios of Ashinam avibactam. We actually want to give Ashinam and avibactam in the ratios of 3:1. So aztreonam-avibactam will have a 2 gram, of which 1.5 gram will be aztreonam and 0.5 gram will be avibactam, and we have to infuse Q6 hourly. So in when we are combining ceftazidime avibactam with aztreonam, we are giving it only 3 times a day, because if you are giving it for 4 times a day, there was a lot of hepatotoxicity. So probably aztreonam avibactam as a compound has a better PKPD, and this is a trial, revisit trial, which compared meropenem against aztreonam avibactam for the treatment of gram-negative infection, and you can see only 25% of this study had a carbapenem production, and you can see that aztreonam-avibactam is shown to be as good as meropenem. Does it make any sense to compare it against meropenem? No, but it was the first trial, so that they can launch the antibiotic. So probably it's time for us to compare a combination of ceftazidime-avibactam with aztreonam-avibactam, and I see no reason why one will be better than other. So, in Indian perspective, it's a great antibiotic we have for Klebsiella pneumonia treatment. And Acinetobacter, the Acinum doesn't have good activity against the penicillin binding proteins of Acinetobacter. And Pseudomonas have other mechanisms of resistance like porine mutation or efflux pump. So, Acinetobacter usually will not be susceptible for Pseudomonas aeruginosa, but it is not wrong to test it in vitro. E. coli, we definitely have a problem because of the PBP3 substitution of 4 amino acids. So there is another interesting antibiotic, cefepime taniborbactam. Taniborbactam is boric acid derivative. A third generation beta lactamase inhibitor. We discussed about it. It acts like a magnet. It will actually attract the beta lactamases and bind to it, and won't detach from the beta lactamase quickly. So one of the advantages of cefepime taniborbactam is, besides inhibiting ESBLs, KPC, and OXA48, it also had some activity against NDM isolates, not NDM isolates, but some NDM isolates. So probably it is very similar to Aztreonam-avibactam. So it has been again compared in a trial in UTI, in a certain trial against meropenem, and it is shown that cefepime taniborbactam again is superior to meropenem in the patients with UTI. So it is interesting. Probably we can look for the susceptibility of cefepime taniborbactam and use it. It could be a good alternative for Aztreonam-avibactam at present. It will be interesting to study Aztreonam-avibactam and cefepime taniborbactam head to head as well. But right now, cefepime taniborbactam is not available in India for use. How about E. coli? E. coli, we discussed a lot about E. coli. So the pandemic clone is sequence type 131, which produces CTXM15. But then you can see in India, sequence type 167, 617, and 410 dominate, and they have a lot of NDM production. So uh, we were thinking that we nailed Klebsiella pneumoniae by giving a combination of Aztreonam-avibactam, but then we started seeing these PBP3 inserts, which make many of the newer antibiotics like Aztreonam-avibactam, cefiderocol, cefepime-taniborbactam ineffective. So what are the options we have? We have to really go for antibiotic options which won't work through penicillin binding protein 3. Two of the options right now we have are phosphomycin and plazomycin. We have discussed about the phosphomycin being one of the smallest antibiotic acting on Murray enzyme, which is the first step in the peptidoglycan synthesis. causing a lot of side effects because we have to use it IV in very very higher doses like 12 to 24 grams per day. But there could be resistance to phosphomycin because of decreased uptake of phosphomycin through GLPT and UHPT, which is required for the phosphomycin uptake. So till now, many of the E. coli isolates which we see in India are susceptible to phosphomycin, and they do respond very well for the to the intravenous phosphomycin. Even though there is not a lot of literature which is published, the uses of systemic phosphomycin in India for carbapenem-resistant E. coli is very very common. What about this new molecule, plasmomycin, a modified aminoglycoside, so that it cannot be broken away with aminoglycoside modified enzymes. However, there are two different types of resistance to aminoglycosides. One is through AMAs, which modify the aminoglycoside themselves. Second is RMTases, ribosomal transferases, which will modify the aminoglycoside binding site on ribosome. So plasmomycin works well for AMAs, but if there is a mutation in 16S RNA methyltransferase, plasmamycin might not be effective. It is definitely acting on the ribosome, so PBP3 has nothing to do with plasmamycin resistance. So you can test for plasmamycin susceptibility in a carbapenem resistant E. coli, and probably if it is susceptible, you can use it. There are two important trials with plasmamycin. One is EPIC study and CARE study. Before this, there was a phase 2 study that plasmamycin is head-to-head compared with levofloxacin in UTIs, and it is shown to be as good as levofloxacin once day for 5 days, right? So this is EPIC trial where plasmamycin is compared against meropenem and UTA, and the plasmamycin is found to be non-inferior. You can see because of the post-antibiotic effect, there are number of relapses are lesser in aminoglycosides compared to carbapenems in this particular study. Again, there is a CARE trial. One of the problem is approximately only 40 patients are there in this trial, so we cannot make any strong conclusions. But plasmamycin here is compared against colistin, and it is found to be probably the mortality in plasmamycin arm is less compared to colistin. But I don't think we can make conclusions from a study with a 40 sample size. How about Pseudomonas? So Pseudomonas, the problem is polymyxins are active. TG-cycline and minocycline, they are not, Pseudomonas is intrinsically resistant to TG-cycline and minocycline. A combination of Asciunam avibactam might not act because of the efflux pumps and OPRD loss or of Pseudomonas. So there are other mechanisms. Even the enzymes produced can be Vim and IMP, where avibactam can be effective against them. So there are other different mechanisms of Pseudomonas aeruginosa, which makes a combination of Asciunam and avibactam very often non-effective in case of Pseudomonas. So what are the other drug options we have? We have cefidericol, which we can use for the treatment of Pseudomonas, but cefidericol is not available in India. And what about other options? So in Pseudomonas, at present, whatever the drugs which you have available, you have a problem, right? So besides polymyxin, kind of you are not able to give any other antibiotic. Polymyxins being having very poor PK/PD without a combination therapy, it becomes very very difficult with Pseudomonas. So sequence type 235 is more prevalent globally as well as in India, but you can see that there are other sequence types are prevalent based on different ICUs within the same country, within the same ICU also. There you can see different sequence type of Pseudomonas aeruginosa. So basically for Pseudomonas aeruginosa at present in India there are not many options, but then there is a new molecule called cefepime-zidibactam, which we discussed about, where it is not a beta lactamase inhibitor, it is a beta lactam enhancer, where zidibactam has a very high affinity for penicillin binding protein 2 and cefepime acts on penicillin binding protein 1 and 3. The combination of this penicillin binding protein binding will lead to actually rapid lysis of the bacteria. So many of the isolates of Pseudomonas in India are susceptible to cefepime-zidibactam. Most of the times the MICs will hover around 16 and 32, and anything less than 64 is susceptible. So cefepime-zidibactam is definitely one of the great options for the treatment of this carbapenem-resistant Pseudomonas. And there are many case reports on the compassionate use of cefepime-zidibactam in carbapenem-resistant Pseudomonas aeruginosa, and the drug is yet to become for commercial use, so we'll be eagerly waiting for it. So this is about management of carbapenem resistant gram negative infections. To summarize it, at present with whatever antibiotics you have available, for Acinetobacter, a combination of polymyxin with high dose sulbactam, or a combination of polymyxin with high dose tigecycline and high dose minocycline or minocycline. For Klebsiella pneumonia, simple Asciunam avibactam. For Pseudomonas aeruginosa, you have only polymyxin. Sometimes we still use a high dose of carbapenem because of the subgroup of overcome trial. We can at least where we can at least see a numerical difference in mortality when high dose meropenem is given, even though not statistically significant. So scientifically, right now we have only polymyxins as an option for Pseudomonas aeruginosa. What about carbapenem resistant E. coli? You can look at the susceptibility of Astronom albactum, but if it is not susceptible, phosphomycin systemic use is a very good options. For UTI, you have as an alternative like plasmomycin for the treatment. So this is the summary of carbapenem resistant enterobacterial infections. I hope that you people have enjoyed this session. We will be discussing about uncommon or rare gram negative infections in intensive care unit in our next sessions. Thank you.